Hello everyone, I am Dr. Anupam here and today we will discuss a very important topic. I will sum up all the recent guidelines that is available for treating hospitalized critically ill COVID patients. Right? So let us discuss. So we will start first discussing what are the available antiviral agents for COVID-19. Right? So let us discuss. So we have basically only one antiviral agent, that is called remdesvir, that has been studied in multiple clinical trials. So we'll discuss two of the major trials that has been published for remdesvir. Let us see. One is Act 1 trial, another is Solidarity trial, right? So the Act 1 said that using remdesivir has decreased hospital stay by 1 to 4 days. However, it also said that no mortality benefit. Right, and also there is no difference in patients requiring either NIV or invasive mechanical ventilation, right? What the Solidarity trial said is actually it is ineffective, right? And Solidarity trial is one of the major trial of remdesivir, which said it is ineffective. Rather, it can increase the length of stay of the patient, right? Now, recently there has been produced a meta-analysis which suggested that, so the meta-analysis suggested that using remdesivir actually improves 28-day mortality, right? But however, it is meta-analysis, it is not an randomized controlled trial, correct? Secondly, it lowers the requirement of invasive mechanical ventilation and decreases the need of ECMO. Meta-analysis also said that it decreases the oxygenation flow in the patient which requires HFNC or bypass, right? So now the current indication will stand at remdesivir should be given for 5 days. Dose will be 200 milligram on day 1, 100 milligram on day 2, 3, 4, and it is only to be given to whom? Critically ill hospitalized patient. Ideally not on ventilator. Right, and it is to be given for 5 days. What are the things to watch for? because the cyclodextrin that has been there with the remdesivir to carry the drug, it is nephrotoxic. So you have to have a look on the kidney function test, and also it causes the liver enzymes to get elevated. So we have to stop it when the liver enzymes are 3 times more than the normal values. So we have to monitor the LFT also. Right? Now coming to other drugs, the second drugs we'll discuss will be convalescent COVID plasma, right? And once and for all, the plasma is not effective. We have done multiple hundreds of trials. It is not beneficial in COVID-19 patients, especially those who are sick and hospitalized. So never ever use it, right? If it is used, it is only to be used in clinical trial setting, not otherwise. So do not use it. Not effective. Only to be used in clinical trial setting, right? Now there are drugs that was used before, now it is not effective, are azithromycin, hydroxychloroquine, or doxycycline, ritonavir, favipiravir, ivermectin, lopinavir, etc. And these drugs are not effective, so do not use them, right? Do not use convalescent plasma. Use remdesivir only in hospitalized patients who are critically ill. Ideally, they should not be on ventilator. Right. So now we'll discuss hypoxemic respiratory failure, which is the major manifestation of COVID-19 because the target organ is the lung. So how to deal with hypoxemic respiratory failure? And there has been multiple studies before also. So how to deal with this hypoxemic respiratory failure, right? So let us discuss one by one. First we'll use low flow oxygen and awake proning, right? As patient deteriorates, that is a clinical decision, we have to use Venturi mask with awake proning. Patient still deteriorates, what to use then? We have HFNC, high flow nasal cannula with awake proning. Right. So what are the indications to start HFNC? Respiratory rate more than 25, PF ratio less than 300 on 10 liter of oxygen for 15 minutes, and PaCO2 should not be more than 45, and no history of chronic respiratory diseases. Right. How to start it? Start with a flow of 50 liter and FiO2 of 1, titrate to SpO2 more than 92% and decrease work of breathing. Now, how to assess HFNC? How to assess, right? This assessment can be done by using a ROX calculator, right? That is to be done at 2 hour, 6 hour, 16 to 2, 12 hour. This is the online calculator available. You can just put the value and get the result. We can have 3 results: more than 4.88, less than 3.85, and in between. If it is more than 4.88, chance of HFNC failure is less. If it is less than 3.85, high chance of HFNC failure, right? So these are the patients who should be given utmost importance and seriousness. These are the patients, they can become bad, so they have to be intubated early. However, the patient who have ROX index in between these two values, they have to be observed and retest at 1 to 2 hours later, right? Now the fourth will be BiPAP or CPAP with awake proning. BiPAP or CPAP have a special group of patients, and they will be patients with acute pulmonary edema, AE, COPD or bronchial asthma, PaCO2 more than 45, or you do not have no HFNC in your center. So in this situation, you have to use BiPAP or CPAP plus awake proning, right? So how to assess? By using Hacker score. Again, there is online calculator. I will not spend much time on it. If the Hacker score at 1 to 2 hours of NIV is more than 5, Hacker score at 1 to 2 hours of NIV, if it is more than 5, then chances of NIV failure is maximum within 48 hours of its use. So these are the patient who has to be intubated at the earliest, right? So if it is more than 5, NIV failure within 48 hours is very high. So these patients, they have to be intubated early, right? Now fifth will be, what is awake proning? What is awake proning? We have seen all the modality of oxygenation we are using with awake proning, so right? So how to do this awake proning? So all the patient, those who can stay in prone position, has to be encouraged to be in the prone position, right? Patient has to be educated. They have to empty their bladder and bowel, and they have to lie prone position, either arms by side or in a swimming posture for at least 4 hours for 4 sessions, ideally 16 hours a day. If it is not possible, then at least 30 minutes for each session, right? If patient cannot tolerate a prone position, then they have to lie either in lateral decubitus, or they can alternate between lateral decubitus and complete prone position. However, these methods are not effective than the complete awake proning methods, right? So how to do awake proning? Number one will be the head end should be elevated by 10 degrees. This is called reverse Trendelenburg position. This is used to decrease the intraocular pressure, right? To lie either arm by side or swimmer position, right? And duration 4 hours a time into 4 sessions. That means ideally 16 hours a day. If patient cannot do it, then at least 30 minutes each session, right? If patient cannot tolerate the complete prone position, they can lie in lateral decubitus. But this is not effective. Or they can alternate between lateral decubitus and complete prone. This is also not fully effective. The effective one is arm by side or swimmer position, complete proning. So when to stop proning? Two conditions. First, patient improves. That means patient can tolerate nasal cannula oxygen less than 4 liters per minute, right? And maintain saturation more than 92%. In that condition, you can stop airway proning. Or second, patient need higher oxygen support. That condition also you have to stop it, right? So this is about airway proning. Now patient still deteriorates. What to do now? Number 6 will be invasive mechanical ventilation. There have been thousands of studies about it. We have ARDS net protocol that will not discuss in detail, but we have to use that, right? And number 7 will be proning. This is not airway proning. So once the patient is on ventilator and he is stabilized for 12 to 24 hours, if after that time also the PF ratio remain less than 150, FY to more than 0.6, PEEP more than 5, and tidal volume 6 ml per kg, it is at the time we can try proning, right? According to the Proseba study, the proning has to be done 16 hours a day. So you could try proning provided there is no contraindication to proning. 16 hours a day, continuous, you have to do this. And how to assess? The physiological variable. So we have to do AVG, SpO2, BP vitals check just before proning and 1 hour into proning, just before supining, and 4 hours into supine, right? These are the 4 times you have to assess the physiological variable, whether your patient is actually improving or not improving, right? So when to stop proning? So sustained improvement in oxygenation, right? How to know that? The PF ratio remain more than 150 with FiO2 less than 0.6, PEEP less than equal to 10, and it has to be sustained for at least 4 hours when patient is supine. It is at the time you can actually think of stopping the proning, or else patient actually become worse on supine. At the time also you have to stop proning, because proning is patient. So when to stop? Patient become worse on proning. So proning is not effective here. So you have to stop. Number 3 is complications. If there is some complication happens, cardiac arrest, hypotension, extubation, self-extubation, or endobronchial intubation, there are a few conditions where you have to stop proning and make the patient supine, right? Number 8 method will be last resort, is ECMO. Specifically VV, veno-venous ECMO, we can do, right? So these are the technique and method for hypoxemic respiratory failure management in COVID-19, right? Or any patient with hypoxemic respiratory failure. Now coming the systemic inflammation or cytokine storm, how to prevent it? There have been studies. So the number one drug in this group will be dexamethasone. Dexamethasone. So there has been studies, the recovery trial. So the recovery trial suggested that there is actually mortality benefit, right? Plus, patient who receive dexa, if they are on oxygen, it reduces mechanical ventilation requirement. A patient already on mechanical ventilation, it helps weaning, right? So dose the recovery trial used is 6 milligram PO or IV into 10 days or discharge. So here one thing is important. It's called a right dose, a right patient and right time. So the steroid has to be started when the inflammation is high. So do not start steroid if the patient is not hypoxemic or requiring respiratory support. So the right patient will be patient who is hypoxemic and requiring a respiratory assistance, right? Do not use in patient who is not requiring any kind of respiratory assistance or not hypoxemic. What is the right time? More than 5 to 7 days after the symptom onset. This is very, very important. In the recovery study, they have shown if it is started less than 7 days or in patient who are not hypoxemic, it actually detrimental. So always start dexamethasone after 5 to 7 days of symptom onset. And in a patient who is requiring oxygen for hypoxemic respiratory failure, requiring respiratory assistance, in those patients only you have to give. These are the right patient and right time, and the right dose will be 6 milligram per kg PO or IV into 10 days, right? So now when to use high doses? When to use high dose of dexa? So simple formula is COVID-19 with respiratory failure, hypoxemia, more than 5 to 7 days of symptom onset, measure CRP. If the CRP is less than 7.5, then the dose will be Dexa 6 mg PO or IV into 10 days. And check daily CRP. If CRP is more than 7.5, here first rule out any infection, right, and other immunosuppression. Then here what you can use, you can actually give Dexa 8 mg IV plus tocilizumab, IL-6 inhibitor, right? If your hospital do not have tocilizumab, if no tocilizumab, in that condition what we can do is Dexa 20 mg per day we can use. This is called high dose Dexa. If you are using tocilizumab, use Dexa 8 mg IV per day. If you do not have toci, then use Dexa 20 mg per day. And this is also supported by the Codex trial, where it is used 20 mg per day into 5 days, then 10 mg per day into 5 days. In any situation, do not use dexamethasone more than 10 days if patient is only COVID-19 infection, right? So now the second group of drug will be IL-6 inhibitor that we discussed here, that is the tocilizumab, right? So the IL-6 inhibitor tocilizumab, according to the REMAP recovery and impact study, they suggested that it actually reduces mechanical ventilation requirement. Right? So the latest meta-analysis suggested that it has to be started in critically ill hospitalized patient with high inflammatory marker. As we discussed, the CRP level has to be more than 7.5 and within 12 hours of organ support. That organ support. The dose will be 8 mg per kg and maximum dose 800 milligram. And single dose, and the dose can be repeated 24 hours later depending upon the patient's clinical condition, right? So then we have JAK inhibitors. Studies are still going on. There is no conclusive evidence to start it at this point of time, right? So these are the agents against the systemic inflammation or cytokine storm, basically dexamethasone and tocilizumab, right? Now there is another thing that is called hypercoagulability. COVID-19 produces a kind of DIC where patient become prothrombotic. So every patient should receive DVT prophylaxis with usual dose of LMWH, right? Do not stop LMWH unless platelet is less than 30,000. Usual patient platelet less than 80,000 to 1 lakh, we stop LMWH. But in COVID, don't stop it unless platelet is less than 30,000, right? And no benefit of high dose of LMWH. So never use it. So it is not to be used, right? And there is no role of aspirin also. So all the patients should be given DBT prophylaxis unless contraindicated, unless platelet is less than 30,000, right? Today we have discussed the recent guidelines of how to treat patients with COVID-19 pneumonia in the hospital. We discussed in the beginning with the antiviral remdesvir. Then we have discussed how to treat the hypoxemic respiratory failure in COVID-19 patient in details. Then we have discussed how to reduce the systemic inflammation, what are the recent guidelines, and every patient should receive DBT prophylaxis. Usual dose, not high dose. Thank you very much. I'll meet you again.